I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course. In this section, I'm going to cover respiratory failure and some of the medications that may be used in intubation. So first off, just briefly on some definitions here. So respiratory failure, it's failure of gas exchange in the lung. You remember that role, the interplay between bringing oxygen in and expiring and eliminating CO2. I mean, that's what the lungs are designed to do. We got to get oxygen to the blood, and our lungs do that for us. And if those lungs are failing, we're losing out on both of those processes, right? So low oxygen is the most common form of respiratory failure. That's defined as a PaO2 of less than 60 millimeters of mercury. Normal or low PCO2 can happen, and then associated with this situation, and then pneumonia and pulmonary edema can happen as well there. Hypercapnic, so this is an elevated PCO2, so that's kind of on the flip side of, low oxygen would be that PCO2 is going to rise. That's, a potential complication from respiratory failure. Certain situations where this is more likely, asthma, COPD, or drug overdose potentially. All right, so management, it's pretty straightforward. We want to, get oxygen levels up in managing that respiratory failure, and we want to get CO2 levels down if that's a potential primary concern as well. So we're going to be monitoring, both of those things for sure. Medication management, first and foremost, we want to try to identify a cause. So, if pneumonia is the cause, we want to treat that infection. Okay, that's pretty straightforward. If we've got excessive fluid around the lungs, we want to run some of that fluid off. We're going to use diuretics in that situation. COPD, talked about both of these examples previously. Utilizing anticholinergics, utilizing beta agonists to open up that airway and try to improve that respiratory status. In asthma, we're going to use those beta agonists potentially in combination with steroids there. So really important to understand what's causing respiratory failure and try to get meds on board right away to manage that situation. Now, if we get to a situation where we've got, too low of an oxygen situation, the patient is not breathing well enough on their own to maintain, oxygen delivery and those type of things, we may have to do intubation. And I wanted to go through a few of the potential sedative agents that you may see. So first and foremost, we've got propofol. This binds numerous receptors in the central nervous system, including GABA-A, glycine, nicotine, and muscarinic or M1 receptors. Very, very quick onset, easily crosses into the blood-brain barrier, so that medication is going to start sedating the person very quickly. One unique thing about this medication is we can have what's called propofol infusion syndrome. This can cause acidosis, so that would be a change in blood pH. You'll see that blood pH go down. It can cause elevated triglycerides, drop in blood pressure, arrhythmias, acute kidney injury, electrolyte disturbances like elevations in potassium, rhabdomyolysis, and even liver dysfunction. So this tends to be more likely with higher dosages and longer use. Okay, so that's an important thing to note with propofol and one of the downsides potentially there. Acutely, it does have dose-dependent respiratory depression and low blood pressure potential. Okay, so obviously, paying attention to blood pressure is going to be very, very important there, that we don't drop that blood pressure too low. Dexmedetomidine or Precedex, mechanistically, this medication works as an alpha-2 receptor agonist with sedative, analgesic sparing, and sympatholytic properties. So again, this is another potential sedative. It's generally not, obviously dose dependent, but it's generally not as strong in that it's more easily able to arouse the patient with dexmedetomidine. It also has the potential for less respiratory depression than comparing it to propofol or benzodiazepines. So that's a potential advantage. With that said, it works similar to clonidine, which I believe I covered in the hypertension section. So if you remember that, the alpha-2 central acting agonist like clonidine, so if you can lump that together with dexmedetomidine, hopefully you'll remember that low blood pressure and lower heart rate are a potential complication or adverse drug reaction. The other benefit is there is potentially a slightly less lower risk of delirium. Downside, onset of action is generally a little bit slower than propofol. All right, now we got benzodiazepines. These activate GABA A receptors in the brain, which leads to those sedative type properties. Elderly may be a little bit more sensitive to the effects of benzodiazepines. Common agents, midazolam, lorazepam, diazepam. Midazolam and diazepam do have active metabolites, and CYP enzymes may cause some interaction here. So that's one of the big downsides there. IV lorazepam does contain propylene glycol, which could cause some dose-related toxicity there. Other potential medications, lidocaine. This can help suppress the gag reflex, so may be utilized as pre-medication in intubation. Possibly helps prevent or stabilize increases in heart rate as well, intracranial pressure as well. Fentanyl blunts the sympathetic response to the physical act of intubation, and obviously fentanyl is an opioid analgesic, so it is a pain reliever as well. And then we've got neuromuscular blocking agents. These cause complete muscle relaxation, paralysis. So this means the patient obviously cannot breathe on their own. Okay, so we are literally paralyzing, stopping the action of respiratory muscles, which allows us for reduced tension and easier insertion of that breathing tube. Talking about these neuromuscular agents briefly here, we've got depolarizing agents and non-depolarizing agents. The only notable, depolarizing agent is succinylcholine. This medication binds and activates acetylcholine receptors, which causes depolarization of skeletal muscle cells and ultimately causes relaxation. Remember, we're basically paralyzing those muscles is what we're trying to do there. Succinylcholine, very short-acting agents. There is what's called a risk of malignant hyperthermia So monitoring body temperature, that's definitely an important thing for nurses to pay attention to for sure. It does not have a reversal agent, so that can be a potential downside. We're going to also monitor labs with this medication as it can increase potassium levels. Non-depolarizing agents, these bind and block activation of the nicotinic acetylcholine receptor at the neuromuscular junction, so just a different kind of area in the nerves and cells there. Commonly mentioned agents, pancuronium, rocuronium, they have varying differences between half-life and onset and those type of things. Not something you generally need to be worried about, but wanted to put those on the list there for completeness sake. All right, in intubation, respiratory failure, obviously this is a very sick patient that's not doing very well. They're hospitalized, they're not moving, those type of things. We got to think about DVT prophylaxis with anticoagulation, stress ulcer prophylaxis. Medications we use there are PPIs like omeprazole, which I'll certainly talk about at length in GERD section and GI sections. Management of issues causing respiratory failure. I went through a few of those at the start, or at least some of the common ones there. If intubation is used, monitor for ventilator-associated pneumonia. So that can be a problem, particularly in longer use of ventilation or intubation. And then minimize sedation as much as possible. We want to get those patients going back and breathing on their own as quickly as we potentially can, and hopefully resolve or help improve the underlying problem that caused their respiratory failure. Nurse monitoring, that airway, we're going to always be looking at that, certainly paying attention to, is the patient able to ventilate? When are they able to ventilate? When can we get rid of, the intubation and that sort of thing? Oxygen saturations, obviously that's going to be important. We got to make sure the other tissues, the other organs are being perfused so they can continue to hopefully function normally. Heart rate and rhythm, blood pressure, no-brainers there. Some of the meds can affect those. Level of consciousness, respiratory effort and rate, all important things to pay attention to. And then any potential signs of difficult airway. Are there, anatomy issues that might make intubation more difficult or problematic? Secretions, trauma. Were they in a car accident? And there's broken bones and other things that are impacting the way we want to manage this patient. So we're just paying attention to some of those things. Struggling with nursing pharmacology? Would you like a resource you can put in your hands? You're not alone. If you want to understand medications instead of just memorizing them, check out the MedEd 101 Guide to Nursing Pharmacology on Amazon. Written by a board-certified clinical pharmacist, this book breaks down high-yield drug concepts, clinical pearls, and real-world examples that actually stick. Perfect for exams and the bedside. Whether you're in nursing school or already practicing, this guide helps you build confidence with medications fast. You can find a direct link to the 233-page book right now at meded101.com/nurse. That's meded101.com/nurse.